Good afternoon, and welcome to today's nonpartisan virtual briefing on supporting health in rural communities. I'm grateful to all of you for taking time out of your day to join us. I'm Alyson Northrup. I'm a senior policy officer at the Robert Wood Johnson Foundation. RWJF is a leading national philanthropy dedicated to taking bold leaps to transform health in our lifetime. For more than 50 years, RWJF has been a trusted resource for data and analysis that inform policies to improve health and well-being. Today, we'll focus on rural healthcare in the United States, including an overview of implementation to date of the new Rural Health Transformation Program established under H.R. 1 this Congress. More than 66 million people live in rural communities. That's 1 in 5 people in the United States. However, rural residents have less access to health services and worse health outcomes. This crisis threatens to get even worse with healthcare prices climbing and hundreds of rural hospitals closing or at risk of closure. Today's discussion will explore the challenges facing rural providers and patients and opportunities to improve health for people living in rural communities. The purpose of this discussion is not to endorse or debate specific proposals or pieces of legislation, but rather to look at the existing body of research on rural healthcare and practical considerations for policymakers and staff. I'm looking forward to the conversation. Before we dive in, a few programming notes. We'll have plenty of time for Q&A, so feel free to share your questions in the Q&A box throughout the discussion. A recording of today's discussion will be shared with you in a follow-up email along with resources referenced during today's talk. Near the end of our time, we'll share a link to a brief survey in the chat. We hope you'll complete it. It really helps us, and we truly use your feedback to help inform future briefings. And lastly, I want to make sure attendees are aware of 2 RWJF resources and 2 new RWJF-funded initiatives related to today's discussion. First, the resources. The Congressional District Health Dashboard is a tool developed in partnership with the NYU Grossman School of Medicine. The dashboard tracks data on health and its drivers by congressional district, including many of the factors affecting rural communities that we'll discuss today. You can visit congressionaldistricthealthdashboard.org to explore the tool and find data specific to your congressional district, as well as state-level data. And for many metrics, you can also view census tract level data to get really granular, more community-level pictures of health outcomes and drivers of health. The second resource I want to flag is RWJF's Federal Policy Bulletin. This is a monthly e-newsletter that delivers the latest research and resources on health policy directly to your inbox. And we'll put a link to subscribe to that bulletin in the chat. The 2 initiatives, before we get to our special guests, that I want to put on your radar. One is the Aspen Health Strategy Group. This group just released its latest report called Meeting the Health Needs of Rural America. The report proposes 5 big ideas to meaningfully improve and invest in rural health and is based on a bipartisan consensus. The second initiative is a new Brookings AEI bipartisan commission on rural prosperity. It's called America's Rural Future. The commission is focused on long-term solutions to strengthen economic opportunity, resilience, and quality of life across rural America. With that, I am happy to introduce our speakers today. Colin Planalp is the Associate Director for Emerging Health Policy Issues at the State Health Access Data Assistance Center at the University of Minnesota. The center is commonly called SHADAC. That's the acronym I'm more familiar with, which is why I trip up on the long name. Heather Howard is the Director of State Health and Value Strategies, or SHIVIS, and a professor of the practice at Princeton University. I'm grateful to have them both here today. Colin, could you start us off by giving us an overview of the state of rural healthcare and trends in access and health outcomes?
Yeah, thanks, Allison. So like you said, I'm going to start with some level setting really about the overall state of healthcare in rural America in recent years, focusing especially on health insurance coverage, access to healthcare, and affordability of healthcare and health insurance. Next slide. To start, I want to acknowledge that the US has made quite a bit of progress over the past decade or so in reducing the number and share of Americans without health insurance. This chart on the left shows the decline in the uninsured rate since 2014. And that matters because health insurance plays a critical dual role in the US healthcare system. First, it helps people to access healthcare when they need it. If you've ever been without health insurance, you've probably avoided going to the doctor. And if you needed a doctor, you likely had trouble finding someone who would see you without health insurance. That's because healthcare providers are taking on a risk by treating people who can't afford to pay for all of their healthcare out of pocket. Second, it protects people from unaffordable medical bills. If you get seriously sick or seriously injured, you could face bills in the tens or hundreds of thousands of dollars. But if you're insured, your health plan typically negotiates a discount on those bills, plus it pays a large portion of them. Without health insurance, many Americans are really just one hospital stay away from financial calamity. But more recently, we've seen an uptick in uninsurance rates nationally, driven by a decline in public coverage, as shown in this bar chart on the right. Next slide. Now I want to shift to looking particularly at health insurance coverage in rural America. What we see are concerning patterns. Uninsurance is higher in rural areas, and there are lower rates of private coverage. Specifically, there are lower rates of employer-sponsored coverage, which is troubling because it tends to be more generous, offering people more protection. But there are higher rates of individual market coverage among people in rural areas. The kind that people often access through healthcare.gov or state-based marketplaces. That's important because the recent expiration of federal enhanced premium tax credits is putting a higher cost burden on people with marketplace plans, and rural Americans are feeling it disproportionately. There are also higher rates of coverage through the Medicare program, with a generally older population in rural areas, and there are higher rates of Medicaid coverage in rural areas, which means they're likely to feel a disproportionate impact from forthcoming changes tied to HR 1, changes many believe will make it harder for many people to stay enrolled in Medicaid coverage. Next slide. I also want to acknowledge that state-level policy choices influence these coverage patterns. Since 2014, 40 states and the District of Columbia have expanded their Medicaid programs as authorized by the Affordable Care Act. And that's a big part of why uninsurance rates have dropped nationally. However, when we look at differences in health insurance coverage between Medicaid expansion and non-expansion states, we see a different pattern for people in rural areas. States that have expanded their Medicaid programs see lower rates of rural uninsurance than states that have chosen not to expand. Next slide. Moving on to talk about access to healthcare, you've probably heard about shortages of healthcare providers in rural areas. This map shows that in stark relief. Let's ignore the gray non-rural counties and look at the orange and blue counties, both of which signify a rural county. All of the rural counties colored orange are counties that have healthcare provider shortages. In dark orange, that means the entire county is considered to have a healthcare provider shortage. And in the light orange, it's part of the county with a healthcare provider shortage. So overall, what this map shows is that more than 90% of rural counties in the United States have health professional shortages. That's across a wide range of providers. It's a challenge for primary care, certainly, but it's even more severe for certain specialties, such as mental health and surgery. And this problem is expected to worsen as our healthcare workforce continues to age in coming years. Next slide. A related issue is the closure of rural hospitals. As you can see from this map, nearly 200 hospitals have closed in the United States in the past 20 years, the vast majority of those in rural communities. And more than 100 of those happened in the past decade alone, with hundreds more at risk of closure due to financial pressures in the coming years. On top of that, we've also seen a decline in specialty services available in rural communities. One clear example is obstetric care. Researchers have documented the closure of more than 200 obstetric units in rural areas over the past 15 years, reducing access to safe and local options for delivering babies. These issues can harm communities in several ways. They create serious economic challenges, since hospitals are often major employers and those jobs can disappear when a hospital closes. And they also create a range of negative impacts for patients who suddenly face reduced access to care, much longer travel times to get the services they need. Next slide. Proximity to healthcare services can be a major challenge for people living in rural areas across the United States. They often face much longer distances and travel times than people in urban communities, especially after a rural hospital closes. And those challenges are compounded when people don't have reliable access to transportation, particularly since rural areas typically don't have strong transit systems. But these aren't just issues of convenience. Barriers to accessing healthcare can lead to people going without the services they need, and that can cause their health to worsen. And in situations where minutes truly matter, like traumatic injuries from workplace or automobile accidents, or when someone's having a heart attack or a stroke, long distances to care can really make a difference between life and death. Next slide. One potential solution that's often highlighted to address these issues is telehealth. It uses video conferencing technology like we're using today, along with other tools, to connect people with healthcare services. Telehealth has been around for decades in the United States, but it really expanded during the COVID-19 pandemic. It holds real potential to connect people, especially those in rural areas with important healthcare services. That's particularly true for specialty care that may not be available locally, such as mental health providers. But there are still challenges to getting the most out of telehealth. As this chart shows, rural communities that could benefit the most from telehealth often face significant technology gaps, including limited access to high-speed internet and the devices needed to use telehealth effectively. Next slide. Finally, I want to talk about healthcare affordability, a challenge that the US has faced for many years. This chart shows the growing gap between healthcare inflation on the top and overall inflation. For most of the 21st century, healthcare costs have grown faster than the rest of the economy, and you can see that here clearly. Ultimately, this affects individuals and families in rural America in two main ways. We pay higher health insurance premiums, and we pay more out of pocket through deductibles or cost sharing, or even the full bill if we're uninsured. And these problems tend to be more acute in rural areas, in part because of basic economic principles. Both healthcare providers and health insurance face less competition in rural markets, and that lower competition contributes to higher costs for rural residents. Next slide. Other factors that influence healthcare affordability are demographics and health status. Rural communities in the United States tend to be older and poorer than urban communities, and they also tend to be sicker. This chart shows that rural people have higher mortality among the top causes of death in the United States. Because people with poor health tend to have a greater need for care, that higher need often leads to higher utilization and higher spending for people in rural areas. Next slide. And at the same time, the high cost can also discourage people from getting the care they need. I mentioned earlier the dual role of health insurance, but that system breaks down when people are uninsured or underinsured, issues we see more often in rural communities. In these charts, we see that people in rural areas report higher levels of trouble paying medical bills, higher levels of delaying or foregoing care due to high costs, and more frequent attempts to save money on prescription medications through risky practices, such as skipping doses and delaying refills to save money. Next slide. That covers my slides. I'm really looking forward to sticking around for questions, but next I'll hand things back to Alyson.
Thank you so much, Colin. That was wonderful. Appreciate you sharing these insights. And as you mentioned, one program that's gotten a lot of attention recently, particularly in rural communities, is the Rural Health Transformation Fund or Rural Health Transformation Program. And this program was created as part of HR 1, in part to offset the anticipated cuts to Medicaid in rural communities. And Heather, I'm going to invite you, and I know you've been tracking this program closely at Chivas, hoping that you can tell us a bit more about what you're seeing.
Yes, thank you, Alyson and the Robert Johnson Foundation for giving us this opportunity to talk about something that is very much in top of mind in the health policy community, and especially among states who I work with in my program, State Health and Value Strategies. It's the largest this Rural Health Transformation Program is the largest single federal investment in rural healthcare. So, of course, there's a lot of interest in it. And Colin, you've done such a great job. I really appreciate your table setting on the rural health context that has given us this Rural Health Transformation Program. So if we can go to the next slide, I'll dig in, and I want to talk about how we got here, and then what we're seeing as CMS has started to implement the Rural Health Transformation Program. And my program, we've been tracking initial state work on this front. And so I'm going to try and lift up hopefully some interesting state examples for you all. So here, the table setting I want to talk about is recent developments in Congress in the enactment of HR 1, the One Big Beautiful Bill Act, which enacted the largest ever, and Colin alluded to this, the largest ever cuts to healthcare programming. And on the bottom left here, you'll see a slide showing the cuts in Medicaid and how those are being felt across the states in rural health. And here, what I'm showing you are estimates that there will be $137 billion in cuts to rural healthcare across the country, in recognition of both the underlying rural healthcare distress that Colin did such a nice job describing, and also the anticipated impact of these healthcare funding cuts. Congress created this Rural Healthcare Transformation Program. It's a $50 billion program spread over 5 years, and I'll be talking more about it. So as I mentioned, it's the largest ever investment in rural healthcare, but it is less than the anticipated healthcare cuts that were enacted alongside this program in HR 1, which, as you see here, are estimated to be $137 billion. So a very important investment in rural health, but smaller than the impact. It's not enough to make up for the impact of these cuts. So that's a tension that we'll be exploring. We can go on to the next slide, where I'll dig into the Rural Health Transformation Program. Here's an overview. It's being administered by CMS, which created an Office of Rural Health Transformation. And so I'll be hereafter referring to CMS and the implementation. It's $50 billion over 5 years, over the course of 5 federal fiscal years. There's $10 billion annually, and all 50 states are eligible to apply. And the good news is that all states applied and were awarded fundings in those initial awards. The funding is by statute. In HR 1, 50% will be split equally among all states that have approved plans, and 50% of the funding is allocated at CMS's discretion. And again, this is in the statute. Going to the right, you'll see the timeline. Things have moved very quickly here. As you all know, last summer, HR 1 was signed into law on July 4th, 2025. CMS released the Notice of Funding Opportunity in September, because Congress set a very aggressive timelines for CMS here. So CMS is responding to the required timelines in the statute, where the awards had to be made before the end of the calendar year of 2025. So CMS released the NOFO in September. Applications from states were due in November. So states reacted very quickly to create their programs and to apply for funding. And then CMS issued the initial awards, announced them in December. That's just a really fast timeline that Congress set out. And I think in recognition of this rural health distress that Colin laid out for us, the need to move quickly. And this implementation, we're now in the implementation period, this 5-year period. And I'm going to mention the initial awards, but I want to note that there will be subsequent annual awards announced at the end of each year, looking ahead to the next year. So if we can go to the next slide, we'll dig in even further. CMS, and I've got a hyperlink in case you want, I know the slides will be shared after if you want to dig in. CMS has outlined 5 strategic goals. None of these will be surprising to people. They're consistent with the healthcare needs in rural areas that Colin outlined and with the statute. One is making rural America healthy again, and a support for innovation in rural areas. And that includes expanding access to healthcare points, a recognition that it may not be a hospital, that there may be other ways of accessing healthcare, and a real focus on preventive health and addressing the root causes of diseases. Another pillar is sustainable access. So a recognition that we need to, there's a real sense that this is one-time funding, but we need to be able to ensure sustained access to healthcare, especially specialty services and emergency care. A focus on workforce development, and that includes recruiting, training, and retaining providers in rural communities. And I would note that there's a mention in several parts that this funding should be tied to a 5-year commitment for those providers. If you're going to be supporting recruiting retainers to rural areas, you want them to stay. And so there's actually in many of these areas, there's a 5-year commitment that these providers have to make. There's a focus on innovative care, the growth of care models that really improve health outcomes and coordinate care. And finally, there's a real focus on technology and innovation. And I think when you see Dr. Oz, CMS administrator, he talks a lot about technology and innovation and wanting this fund to foster those technologies. We'll go on to the next slide. As I mentioned, half the funding is available to all states, but half is available based on discretionary funding factors. So of course, states were very interested to see how CMS might flesh out those discretionary funding factors. And some of them are probably quite obvious to you all: the rurality of the population, and also the proportion of rural health facilities in the state. So those are very concrete criteria that CMS developed. Also, they were looking at, for the hospitals that are in rural areas of the state, how much dish funding are they getting? What is the proportion of uncompensated care they're providing? But I would note also that CMS actually is leaning into the discretion that the statute provides them to look at other factors on which they could score states, and CMS calls those state policy actions. And here I've lifted a number of them from their NOFO. They're scoring states on where they can show commitment to administration priorities on state policies. And that includes, for example, including nutrition training in CME. And a number of states are already moving on that front, where states are expanding access to short-term limited duration insurance plans, reinstating the presidential physical fitness test. There's a number of areas where states can relax or eliminate certificate of need requirements and get additional scoring points from CMS in their applications. Licensure impacts, meaning States we know are the primary licensing authorities for healthcare professionals, physicians, nurses, pharmacists. There's an incentive here if states enter into licensure compacts in terms where maybe they're recognizing where another state has granted a license and making it easier for that state to recognize that out-of-state license. There's also additional scoring points for states that expand scope of practice for healthcare providers, allowing healthcare providers to practice to the top of their license. And that is one way you can expand the number of providers in rural areas. It may not be a physician, it may be an advanced practice nurse who's operating with independent practice authority. There's also a focus on states reducing barriers to telehealth. And finally, there's additional points for states if they if they apply to the federal government for waivers restricting access to non-nutritious foods in their SNAP waivers. So these are all state policy actions that were credited with additional scores in their applications to CMS. If I can go to the next slide, we can talk about what states can use the funds for. Here, CMS has laid out a number of allowable uses of funds. As I mentioned, states were very eager to apply and eager to explore what they could use the funding for. So I won't go through each of these, but you may be interested to see the kinds of examples where states can use these RHTP funds. I would note two areas where CMS has indicated restrictions on state fundings. First, states cannot use this new funding to supplant existing state funding. And that's a common thing the federal government will say is, we want this new funding to be used for new initiatives to expand access, not to supplant existing. Another interesting component is that CMS has said that states can't use more than 15% of the funding they receive for health provider payments. So I think that I have seen some hospitals that are facing rural health distress have expressed some concern that states are limited in how much of this funding can go directly to healthcare providers. Now let's go to the next slide. All states, as I mentioned, states are, of course, always eager when there's federal funding on the line to apply. But in particular here, given the baseline of rural healthcare challenges, and then states always, and I think particularly this year, we're seeing in state budgets that states are facing their own tighter fiscal constraints in this upcoming budget cycle. So they were very excited to apply for this new funding opportunity. All states applied and all states were awarded funding. This is just showing you the average was $200 million. The smallest amount was New Jersey at $147 million and Texas at $280 million. We can go to the next slide. Here, I thought it might be interesting to lift up some interesting examples of state initiatives. Alabama is really leaning in on maternal health and addressing the maternal health crisis that we know is a problem, of course, nationally, but they've leaned in and they have some interesting ways of using IT to expand access to care in rural areas, including telerobotic ultrasound devices and providing labor and delivery carts to help enable this So there might be somebody at University of Alabama, Birmingham, who's an expert but there's a telerobotic ultrasound device in a rural area that's connecting an expert. Michigan, focusing on the healthcare worker pipeline. How do we recruit young people earlier into the healthcare pipeline? How do we integrate more community health workers in chronic disease prevention? We know that community health workers are a cost-effective model to expand access to care. Montana created the Montana the Rural Center of Excellence, which is overseeing a significant restructuring of care availability and access in recognition that there have been rural hospital closures and trying to make sure there's access, but it may not always be in a hospital setting. They're also modernizing their emergency medical services. North Carolina has created and has committed to building 6 regional, what they call NC Roots hubs. And they're in particular focused on transforming the delivery of care in for substance use services, including mobile opioid treatment programs. And finally, Texas it has proposed creation of the Lone Star Advanced AI Initiative. And I see we already have a question in the chat about AI. So I'm glad that I lifted up what Texas is doing. And what Texas is trying to address is real fragmentation of specialty care and how can they use AI in telehealth networks to connect primary care providers and their patients to specialty care. So these are just some examples. And, I work with states across the country and sort of love, just like I love, all of us love all our children. States are all doing interesting things, but I just thought this might be an interesting way to show you across the country, diverse state examples. If we can go to the next slide. I want to leave you with some key considerations from a state perspective. And Alyson didn't mention this in my introduction, but I am myself a recovering state official. I was New Jersey's Commissioner of Health and Senior Services. So I'm always thinking about how states are approaching these. And now in state health, with state health and value strategies, that program, I work with state health officials. And here are some of the ways they're thinking about this. First, this is a very exciting opportunity since it is the largest federal investment in rural healthcare. And so from a state perspective, it's great. But I think I pair that with my second point, which is this is one-time funding, which is exciting, but it's not ongoing funding. And the cuts in HR 1, which I talked about, the estimated $137 billion cuts in Medicaid funding to rural areas, those are ongoing. So we've got a mismatch between one-time funding and ongoing cuts. And those cuts are coming into line in the out year, are just starting to be realized, and they're ongoing. So from a state perspective, that's something they're very cognizant of. I think another thing states are dealing with is there are financial risks and timing challenges here. They've had to move very quickly because of the statutory requirements on timing. And so they're, of course, excited that the funding is coming that the first grants are coming this year. But they've ramped up that programming quickly, and they've made commitments to the federal government in their applications. We plan to do X, Y, and Z. For example, maybe we will enter into a licensure compact with other states. So we'll recognize nursing licenses from other states, or we will we'll get a SNAP waiver, or we'll do these things. They're promising to do them. But CMS has also said, we may claw back the funding if you don't, or even reduce future awards if you don't do the things you're promising to do. You're promising to set up XYZ Center and create this program. So if they can't implement the proposals on these aggressive timelines, they risk that clawback, or even in future funding awards getting less than they might have hoped for. So there's a timing and financial risk challenge that states need to be thinking about. Now, what are some themes we're seeing? States are really excited to focus on expanding and strengthening their workforce, infrastructure and technology clearly, and then value-based care models to improve care. And finally, I would say, having been a state official, and one thing something we're seeing across the country is states recognizing that success of this program is going to depend on strong planning. I think states are off to a strong start with their planning. Engaging stakeholders, it's really important to be engaging rural communities and grounding your proposals and your programming in the needs of those rural communities, and accountability and being able to measure and effectively evaluate how these programs are working. I think I have a few more slides. If I can go to the next one. Yes, I want to leave you with this, which is a few resources. So on the left, what I'm showing you as CMS has helpfully done 50 state spotlights. And I just picked Alaska to show you, but for every state, and there's a hyperlink here, there's a summary of the state's approved rural health transformation program, including some of the themes, certain initiatives, and how the state is estimating that these initiatives will impact rural health. So for those of you who may not who want to know more about their own state or want to see what some other states are doing, this is a wonderful resource, and this is a hyperlink. On the right, what I'm showing is my program, the State Health and Value Strategies, an initiative funded by the Robert Johnson Foundation. We've been tracking state implementation, and here on this map shows you one way we've been tracking is which state agency is the lead. So only states are eligible to apply, and CMS required governors to identify a state agency as the lead. So we've been tracking which states agencies are taking the lead. It's sort of interesting to see the variation as you look across the country. I don't think there's a right answer. It depends on, it's very organic to how state governments and rural health work has evolved over time. We also, if you go to this website, you can hover over a state, and we have links to many states have dedicated web pages to the rural health transformation programs. Many states have ongoing stakeholder engagement processes, and we link to those too. So some resources that you may find useful. And I think that is my last slide, so I can turn it back to you, Alyson.
Thank you so much, Heather. That was incredibly helpful, especially as many of us are working to understand this new program, what it could mean for rural communities, and where gaps may remain. We are now going to turn to our audience Q&A portion of the webinar, and we are not short on questions. We received many questions in advance, as well as several in the Q&A box. Folks can continue to add questions via the Q&A box, and we'll get to as many as we can, though I'll apologize in advance. We're probably going to run out of time and not get to everyone's questions, but you can always also follow up with myself, with Heather, with Colin, with specific questions that you have that we don't get to. All right, I am going to start with one of the questions that we got in advance, and Colin, that you touched on a bit, which is related to transportation in rural communities. So the question is, can you talk about transportation barriers facing rural communities and any innovative solutions you've seen to address these barriers? I know you touched on this a bit in your presentation, but is there are there additional examples, or is there anything you want to go deeper on this topic?
Yeah, thanks. One thing I want to point out is that looking at differences between rural and urban communities in distance to healthcare, there's quite a bit of variation. On average, there's more distance and more time for people in rural communities. But when you're talking about communities that are on further from healthcare, it can be much further. So for some of these communities, it can be an incredible burden to get to healthcare services. Another thing, talking about innovations, I used to, before coming to SHADAC, I used to work at an academic medical center in central Missouri, and that included a hospital that served a number of rural communities in the central part of the state there. And they engaged in certain activities designed to reduce that transportation burden. And there were also other, for instance, nonprofits that operated things. The hospital, for instance, it had some clinics that were open part-time in some communities that couldn't support a full-time clinic. So it may be open 1 week a month or 1 or 2 days a month. They also had a mammogram van that would drive around to rural communities to offer breast cancer screening services. One challenge to those kinds of services is they're generally not financially self-sustaining. Those are things that these hospitals or healthcare providers engage in as a service to their communities. But when these healthcare providers are under financial stress, they're less able to engage in those kinds of activities. So that's one concern I have there for those kinds of hospital-based innovations. But like I said, there are nonprofits, for instance, in Missouri who run volunteer networks where someone can call in or log into a website, request a lift to the hospital or their clinic, and they pair these people with volunteers who then go pick them up at their home, take them to the clinic, take them to the hospital, arrange rides home. So there are innovative solutions both at the provider level as well as community delivered solutions.
Right. And Heather, were there things that came up in the Rural Health Transformation Fund applications that you want to highlight?
Yes, thank you. I'm so glad we got this question. As Colin noted, transportation is one of the most consistent barriers to accessing care in rural areas, and in particular, non-emergency transportation is a vital benefit in the Medicaid program. And so we saw in our review of the applications several examples of states doing interesting things. Pennsylvania is proposing to modernize their non-emergency transportation benefit in Medicaid, and one thing they're proposing to do that I found super interesting is they want to expand the availability of car seats. So they're updating their ride policies so that would allow children to accompany caregivers. Often caregivers forego appointments for themselves if they can't take their children with them. So they're going to provide car seats and update those policies. Oklahoma proposes expanding an existing transportation pilot to include recruiting volunteer drivers and centralizing coordination. So, so that seems a very clever response. And finally, I would say that a consistent theme is this use of mobile clinics and going to people where they are rather than expecting them to come to care. And that includes even providing care at home, as we saw in the Michigan example. I think I glossed over that, but Michigan wants to expand care at home. So a number of innovations.
Thank you both. That's really helpful. I want to shift to a question about older adults. And the question was, where do older adults, aging services, and long-term services and supports fit into the Rural Health Transformation Program? Before we jump to the program, Colin, I'm wondering if you can just talk generally about older adults in rural communities as a table setting.
Yeah, so I mentioned this briefly, but we know that rural communities on average tend to be older than urban communities. We also know that their populations are aging more rapidly because they don't have the same birth rates generally as more urban and suburban communities. We also know that these older folks in both rural and urban communities tend to have higher disease burden. So they're more likely to have conditions like heart disease, diabetes, cancer that require more healthcare services and different kinds of healthcare services. And that's something to keep in mind for these uniquely older rural populations.
I'll jump in and say, as Colin's laid out, that this conversation about supporting access to care in rural communities is deeply tied to concern about serving the aging community. And we saw that throughout state applications. For example, 33 states proposed initiatives that were focused on healthcare workforce development specifically for aging populations and expanding the direct care workforce. But I would note too that the states that were thinking about providing help in the home were very cognizant of how critical that is for helping the aging population. Another 32 states, so we're talking about a majority of the states proposed initiatives to build upon the long-term care system and thinking about how to strengthen nursing home care for those who need that level of care and supports. And 25 states really honed in on improving care for the duals. Those are care coordination for people who are eligible for both Medicare and Medicaid. And then finally, 11 states proposed initiatives to support family caregivers. And those are really important because they're filling in workforce gaps created by shortages in rural areas. And so it's important to support the family and friends who are serving as caregivers.
That's great. And while we're on workforce and healthcare workforce, there was a question about, can investing in non-physician professionals help improve access in rural areas? I'm going to go out on a limb and say yes. But I'm wondering if maybe, Colin, you can start to add more color about what that can look like in rural areas.
Yeah, it's a really interesting idea that states and the federal government have been working to varying degrees to promote for at least a decade or more. We see this with growing numbers of, for instance, family nurse practitioners, physician assistants, those kinds of folks. That can be useful in at least a couple of ways. One is when we have a limited supply of physicians that is contributing to this healthcare provider shortage, we can get some of these folks out to communities that don't have physicians or the right kinds of physicians or enough physicians. Also, it tends to be quicker and thus cheaper to educate and train some of these non-physician healthcare providers. And that can be a strategy also to address the problem of high and rising costs for healthcare in the United States. So it's one of those strategies that can benefit the system in multiple ways. It's not always easy. One problem is we already have shortages of some of these other kinds of providers. So we need strategies to increase training to ensure that these folks are getting out to the communities, such as rural communities, that could really benefit from them. And that's something that both the federal government and the states can have a role in supporting.
And I would just jump in and add, I mentioned that under the state policy actions that states are incentivized to adopt, one is to expand the scope of practice so that we're expanding the healthcare providers in rural communities. And one that Colin didn't mention that I think is worth lifting up is pharmacists. And so there are extra points were awarded to state applications when states said they were going to give pharmacists full authority to practice to the top of their license, and basically expanding what pharmacists can do. So that's just another example of how you can expand care in rural areas.
Thank you both. Heather, you talked a bit about the criteria for applying for the Rural Health Transformation Program, and we had a question about tribes and tribal organizations, and another question about healthcare providers and hospitals. So, and territories or freely associated states, were they eligible for applying for funding? And if yes, then did we see that show up in the applications that were received?
So yes, that's great. Those are a couple different issues that come together. This goes back to the actual language Congress enacted. Only states were eligible to apply for the Rural Health Transformation Program, so not territories, nor sovereign tribal tribes or Indian health organizations. So I understand that probably is causing some frustration. We know there are hundreds of federally recognized tribes, more than 7 million Native Americans and Alaska Native people in the U.S., and we know that those populations face lower life expectancy, have among the poorest health outcomes, and compared to other demographics. So it's a very important issue. Although they could not apply, tribal entities could not apply, the good news is we're seeing a number of states say that they're going to work with tribal entities. So they're perhaps Idaho, Nevada, and Oregon are setting aside proportions of their funding to distribute to the tribes. Washington proposed setting aside $20 million a year. Several other states have very consciously conducted tribal consultations or listening sessions ahead of the deadline. So I think states, especially with significant tribal populations, many of them are fortunately at least consulting and working with and making tribal organizations eligible for funding under their allotments.
Thank you for taking my multi-part question brilliantly. We have about 7 minutes left for Q&A, and we have more questions that we've received than we'll get to. So I'm just going to take a breath, and I want you all to do that too in the audience. There's so much interest in this topic that's really coming through for me in this briefing and the engagement. So I want to thank everyone for the fantastic questions that you're submitting. I'm going to turn to, we talked a little bit about AI in the applications from states for the Rural Health Transformation Program. This is broader than the program, but about AI. How do you think AI can be used to address the issues of doctor availability and distance challenges? And then I don't know if one of you can field this one as well, but there was a question about AI and HIPAA and so how those could be integrated as we move forward with this new technology.
I'll start with how we saw AI playing in the applications. And I think there's a lot of excitement about the potential of AI. It's a very powerful tool, obviously, but there's also a lot of uncertainty about its use in healthcare, and especially as the regulatory framework is evolving. So what I would say is that what we saw in the applications is that the federal government was encouraging states to test AI innovation, especially in increasing access where there are provider shortages. I don't think anyone at this point is saying that it's going to replace providers, but it might extend the ability of providers. So a couple thoughts on that. One, we saw several states in their application identify remote patient monitoring as a proposed initiative, and within that would use AI to review large batches of vital signs and identify early warning signs. So this allows doctors and nurses to monitor more patients when they're addressing distance challenges. So I would say that's one example. But a note of caution would be, we know in rural areas there are longstanding broadband challenges. And CMS has said that our rural health transformation program can't be used for broadband, for building out broadband access. So we may have a chicken and egg problem there, in the sense that where we have broadband access problems tend to be in rural areas, and that's where we're sort of excited about the potential here. So I think that's one to watch. And Colin, I'm guessing you too, I wouldn't want to venture a guess on the HIPAA question. Do you have any thoughts, Colin?
I'm not a HIPAA expert, so I don't want to go down that route. And I have just a few things to add to what you were saying, Heather. I think one is, as you noted, that part of the hope with AI is it may allow healthcare providers to deliver care more efficiently. So perhaps that could reduce costs. That could also allow them to see more patients. One of the concerns that I have, though, especially for rural communities, is rural healthcare providers, rural healthcare hospitals. I talked about how they tend to be under greater financial stress. So I have questions about whether they will necessarily have the capital that they would need to invest in AI tools that could help them to more efficiently and effectively care for the patients in their rural communities. I think that's something that we always need to keep an eye on as we're thinking about ways to better serve these rural communities and ensure their health. Is these rural healthcare providers are under really severe stress, and we need to think about whether the things we're hoping they can do and asking them to do are feasible based on their finances.
Right, thank you. I'm going to jump to a question about evaluation. Would either of you be able to talk about evaluation for the Rural Health Transformation Program? Are there evaluation and monitoring guidelines? Has funding been allocated for those efforts? And do we expect outside of government for there to be robust evaluation and tracking of how these funds are being utilized? Whoever wants to bite. Heather.
I'll start by saying that CMS has set up very clear requirements for reporting. So there will be what I would call reporting and monitoring, and that some of that goes to CMS is doing its own monitoring as part of, since this is a multi-year program, and will be calibrating subsequent year allotments based on how states are doing. So there will be significant monitoring. In terms of evaluation, I have not seen any states discuss dedicating funding, and there's no mention of that I have seen on evaluation. But I think it's an important question, because one hope here is, because, as I hope we've demonstrated, there's significant variation across the state. So there's going to be a really important opportunities to learn what's working and to learn from this. So I'm not certain about that. Colin, do you have any thoughts?
I guess the only thing I would add there is that really the U.S. policy system really depends on research and evaluation. That's how policymakers can decide what policies are effective and efficient so that we can scale up those policies, and which policies aren't delivering on their promises, which policies may be nice, but they aren't cost effective. And that's why I and my colleagues at SHADAC really encourage states to evaluate programs such as this, even when they are not required to by the federal government, and why we work with states and helping them develop frameworks for conducting evaluations, in some ways helping states to conduct evaluations. That can also help one state learn from another state. This worked next door. Maybe we should consider trying it. So even when states aren't required to evaluate components of their transformation work, I think it's important that they consider it because they can benefit from it.
I want to sort of plus one that heartedly, because that's our tracking of what states are doing is really to encourage states to be as transparent as possible, because that's the only way we can learn from this and really promote accountability. So that is, so far states have been very transparent, and that my hope is that they will continue to be.
I'm going to squeeze in one final question and then close us out. So this is a question broadly about rural health and the role of community health workers and community-based organizations. So how can community health workers and community-based organizations support rural health? What are the different types of roles that they can play? Colin, do you want to take this one? Start us
Yeah.
off.
I can't speak specifically to community health workers other than acknowledge that they're another kind of health professional who can help come into the system, help it work in new ways that it didn't work before, or work more efficiently as we have health professional shortages. Also acknowledge that role of community. I mentioned that community organization in the state of Missouri that connects people who need transportation to volunteers who can help deliver that transportation. That's a community-driven initiative, in part because communities in Missouri saw that need and they could step up. Communities know what's needed in their communities, especially rural communities. So they have an important role in helping to identify gaps and, in some places, find solutions to gaps.
Heather, anything you would add?
Yes, I mean, I would agree that part of this, to tie it back to our transparency discussion, is that as states are posting their applications, as states are conducting significant stakeholder engagement, that's where community-based organizations and members of rural communities can engage in the policymaking process, can weigh in, can hold policymakers accountable. And so I think there's real opportunities for that here. And specifically to community health workers, they're really an essential community-based workforce. And states have been leaning into expanding access to community health workers through their Medicaid programs. And I'm hopeful they'll see this opportunity. We noted an emphasis on community health workers in a number of state applications. So I think we'll be learning more from that.
Great. We are fast approaching the close of our session. I want to extend a huge thank you to Colin and to Heather for sharing their insight, their expertise, their experience. I want to thank all of you for participating so eagerly in this discussion. We appreciate your time, your interest. We've put a link to in the chat to a brief anonymous survey. We appreciate you completing it to help us plan future events. We will provide a recording of this webinar, the link to the survey and the resources shared today in a post-event email. I want to thank you all again and wish you a great rest of your day.